Hi, this is Dr. Clark Brittain of Bloomington, Indiana. I'm a board certified gynecologist. I did family practice, I delivered a lot of babies. I was a military physician in Central America for a number of years. And I came to Bloomington to live, work, retire, and die, hopefully in that order. And I have developed an interest as I age in the care of the aging woman. As a gynecologist, that's a large part of my practice. And so, as a young physician, I didn't have very much to offer the aging woman because this was almost like prehistoric time by the way we reflect on things now. But in those days, we really didn't have much to offer women. And I really, as a young doctor, I was more interested in more glamorous things. I wanted to set bones and do surgeries and deliver babies and all that sort of stuff. And I thought of menopausal women as kind of whiny and needy. And now, as I'm an old guy, these newly menopausal women, they're quite a bit younger than me, and they seem alive and vivacious, and I can actually do something to help them. So what I do is I do these consultations where women will come in and they have gotten to know that I can help them with their hormones. And as Dr. Neil Rousier wrote in his book called the Healthy Aging, he writes about the importance of hormone maintenance as we age. And I'm going to just do a little graphic to highlight that. So if you look at your hormones as an aging process, here's childhood, here's puberty, here's the reproductive years, perimenopause as the hormones are declining, and then menopause. And the misconception about menopause is that it is not just this right here where you're going through the change. That's perimenopause. There's a medical term for it called the climacteric. But it leads to menopause, which is forever. And there's a incorrect term, I think, called postmenopause. To me, postmenopause means you're dead. Menopause is all of this. Postmenopause means you're in the grave. So every woman, regardless of how she lives her life, her ovaries are going to poop out around the age of 50. And the average age is maybe 51, 52, but on average about then. If she becomes menopausal because of surgery, she might go like this: childhood, puberty, reproductive years, and then boom, fall off a cliff here at maybe 40 years of age, and then she's menopausal forever. And if she keeps her ovaries, then it's that same progression like this. The change that happens right here is kind of like this. There's these stagger steps until the ovaries completely quit producing the hormones that are so vital. And in menopause, the average woman loses about 90% of her ovarian estrogen production and the vast majority of the testosterone production, most of her progesterone production, and some others. So let's just review real quickly what that means. Estrogen helps with hot flashes, night sweats, concentration, memory, mood, vaginal lubrication, skin texture, joint lubrication. In fact, our rheumatology colleagues say that their patients who take estrogen in menopause have less pain than their patients who don't. Even though it might not modify their disease process, they have less pain because the joints are lubricated. So with the loss of testosterone, you have problems with concentration, memory, mood, strength, endurance, sexual desire, and with the loss of progesterone, it affects mood and sleep and calmness. Think about this, women who breastfeed their babies in the main are a pretty calm group of women. And they have sky-high levels of progesterone. And it has a biological requirement to help make milk and to protect the uterus, and it acts as a contraceptive function, and it helps the brain. It has a sedative effect in the way it's metabolized. So when you lose all of these things, the estrogen, testosterone, progesterone, and menopause, oh my gosh, it's a huge hit to the overall well-being of the body. I hear this story from women a lot. They went to Dr. Jones and they were 50 years old and they're having trouble with irritability. Dr. Jones says, here's your Xanax, have a nice day. 6 months later, they go to Dr. Jones and they say, Dr. Jones, I'm having trouble sleeping. Here's your Ambien, have a nice day. 6 months later, they go back and say, Dr. Jones, don't you know I'm blue? Here's your Prozac, have a nice day. If Dr. Jones and other physicians like Dr. Jones, he or she might ask the patient, is there anything else going on besides trouble sleeping? Do you have any other symptoms of, midlife change? And if they did, they would actually try to treat the root cause of these problems rather than treat the symptoms. No one has a Prozac deficiency. No one has a Xanax deficiency. No one has an Ambien deficiency. But when you have this perfect storm, this trifecta, if you will, of the loss of these hormones, oh my gosh, it's like having the rug pulled out from under you. So some of the challenging things, and I go through this with my patient, I'm going to come back to why there's a little bit of a controversy in a minute, but go back to this graphic of childhood, puberty, reproductive years, perimenopause, menopause. It's not quite that easy. You had childhood, and then maybe some of you remember, puberty was kind of like this. Reproductive years, things are working pretty good. You were able to have sex, you had babies, you had a brain, you could work, you were working out. Perimenopause comes along and it does this, so it's kind of fits and starts until you poop out completely. So sometimes when we're on this slope here, it's a little hard to treat that because it's almost like a moving target. Well, there was an unnatural, or I guess maybe a mistaken idea that somehow or other hormones weren't good for us, based on a kind of a flawed study that got a lot of publicity that was begun in 1997. And maybe some of you have heard of the Women's Health Initiative. They took a group of women and they were menopausal and they were treated with a placebo. And they wanted to compare them to women who took Premarin, which is pregnant mare's urine estrogen and a kind of a synthetic estrogen, if you will, from animal source. And then compared those two groups of women to a group of women taking Premarin plus a synthetic progesterone. There were 9,000 women in each group. They started this study. Things were going along fine. It was one of those classic studies where the doctors didn't know what the patient was getting. The patients didn't know what they were getting. So this is considered pretty good science. At the end of 5 years, the investigators looked at the codes and looked at who was taking what and what kind of health problems they were either having or not having at the end of that 5 years. Well, they noticed that the women who took Prem Pro, the synthetic estrogen, synthetic progesterone, had a higher incidence of breast cancer than the women who were taking Premarin or placebo. So they said, ethically, we should probably discontinue that part of the study. So they did. They continued the Premarin and the placebo study for another 8 years, but the public media got a hold of that without the knowledge of what was in this medicine, and they said, oh my gosh, estrogen's killing women, quit taking it. Thousands of doctors saw this public media outrage, and millions of women saw this public media outrage and said, I'm not taking that stuff. I don't want to get breast cancer. And so it was an absolute disaster from a public health perspective. The investigators continued that study for another 8 years, and lo and behold, at the end of the 13-year time frame, the women who took the Premarin, which is this estrogen, actually had 20% less breast cancer than the women who took nothing. Well, there's two problems with this. First of all, the leading cause of death in menopause is not breast cancer. Maybe the scariest thing, but it's not the leading cause of death. Leading cause of death is heart disease. More women die of heart disease in menopause than the next 16 causes of death combined. So I read that original study in 2002. I thought, oh my gosh, here's a gold mine. I've been interested in using estrogen to treat my patients. And looky here, here's proof from a randomized controlled blinded study that's the capstone of biological research that's saying estrogen can reduce the risk of breast cancer. Wow, that's pretty cool. A few years later, there was a big study in Denmark that followed 698,000 women, and it was a national registry study. They have a unified healthcare record in Denmark, so virtually all the menopausal women, well, everybody's in this registry, but they looked at the 698,000 women who were between the ages of 50 and 59 at the time they wanted to start the study, and they looked at what they took for 7 years in terms of hormone replacement therapy, and then they wanted to find out who got heart attacks and who didn't. Well, lo and behold, the women who took estrogen by itself, not swallowed, but either on the skin, under the skin, or in the vagina, cut the risk of heart attack in half compared to women who took nothing. Women who took Prempro had an increased risk for heart attack. And so I share this kind of information with my patients, and you just start to see the lights come on. Oh my gosh. Oh, and I'll feel better? I want this. So my wife is a local physician, Dr. Mary Maynard. She's a wonderful person, wonderful doctor. And she and I are, getting to be old timers, and we have an interest in taking care of mature people. So we went to the International Menopause Society's World Congress meeting in Vancouver, Canada last year to just pick the brains of these smart people from all over the world who take care of menopausal women. They're from Africa and Asia and Europe and North and South America and Australia. And virtually every one of them said, take hormones, take hormones, take hormones, don't stop. But it matters what you take and how you take it. So what I tell my patients is the active ingredient of this Prempro that was causing the problems was this synthetic progesterone. It's not even a progesterone, it's called a progestogen. And that was what was aggravating the risk of increased risk for breast cancer, was this synthetic progesterone. So we just simply use natural progesterone. You got to use regular estrogen like your body naturally makes. You use regular testosterone like your body naturally makes. And when you do that, if those hormones are good for you during these reproductive years here, just because you quit making them doesn't mean they quit being good for you. They're still good for you. And the North American Menopause Society says, keep taking it. It's okay. You don't have to stop. There's no evidence whatsoever that says you need to stop taking those hormones. You can take them forever as long as you're doing it in an intelligent way. So when I bring this information to my patients, I also share with them the information from the American College of Obstetrician Gynecologists. I'm board certified by them. I'm supposed to kind of follow the guidelines that are promoted by them to maintain a fellowship in that society and good membership status. And so they published a series of articles recently that said, in menopause, unless there's some specific contraindication, menopausal women should be on hormone replacement therapy. And that women who do reduce their risk of death from preventable disease by as much as 50% compared to women who take nothing. Now, that should be shouted from the rooftops. Everybody needs to know this. And there really aren't very many contraindications to taking these hormone replacement products. But it's got to look like what your body makes. It has to get into your body looking like what you naturally make. And when you do that, you can feel good. You can have that vibrant life. And in fact, I'm so enthused about that name that I've actually named my private practice Vibrant Life to manifest how enthused we are about the work that we do and the improvement in the lives of the patients with whom we're granted the privilege of treating. So when we do this, we see a reduction in risk for heart attack, reduction in risk for stroke, reduction in risk for breast cancer, reduction in risk for colon cancer. And in fact, there's a pretty good editorial in the most recent publication from the American College of Obstetrician and Gynecologists, the monthly edition of their scientific journal, where the lead editor has been studying menopause for about 25 years, says women who take estrogen properly reduce their risk of getting Alzheimer's by about 30% compared to women who take nothing. And if there's nothing else in the world that would urge you to consider taking estrogen, I can't imagine that you'd want to not have the chance to reduce your risk of getting Alzheimer's. Alzheimer's affects 6 million people, the third leading cause of death in the Americans today. So if this information is of interest to you and you want to get a little bit more information, please visit my website, www.drbrittain.com. We have a Facebook page called Vibrant Life, VIBRANTLIFE. We have an office phone number, 812-331-9160. And even if I can't reach out to treat you or connect with you, maybe you have a friend in the area who might want to get some help, or you might want to take this information to your physician and share with them, because a lot of doctors don't know this. And you can actually help educate your doctor to make your life better. Have a great day.